Good afternoon to everybody. Welcome to the live international webinar on nursing life in pandemic, compassion or compulsion. So it's a real joy to invite each one of you for this webinar organized by the Fundamentals of Nursing Department of the Madras Medical Mission College of Nursing. It's a real joy to be together, though we are all maintaining a social distancing, but still we are all together, connected to learn. So this is a nice, interesting topic which is organized by the Fundamentals of Nursing Department. So let's start with a word of prayer, because organizing a conference is easy, but organizing a webinar is a challenge because of the technology. So we'll just commit the session into the Lord's hand and we will proceed. Let's pray. Our gracious and loving Heavenly Father, Lord, we thank you for this time of connectivity which you have given, where we can share our knowledge with each other. Thank you, Lord, for being with each and every one of us and our families thus far. Your protection, your guidance has been a great source of support to each one of us, Lord. We thank you and praise you. So as we share our knowledge together, we commit the speakers, the participants, and the technology into thy mighty hands. Take control of every situation. Let honor and glory be to you alone. In your mighty name we pray. Amen.
Amen.
So once again, it's a joy to have each one of you here. So shall I hand over the session to the Fundamentals of Nursing Department? Sashikala will take over, and she will welcome the speakers. And it's a joy to have Selma and Saumya with us, who are in the clinical field, who will be sharing their expertise, especially the challenges as a staff nurse when you work in the area, and as a nursing supervisor. The challenges which they face in the area is enormous. And as you know, this COVID-19 pandemic has put all of us in so much of anxiety about ourselves, and we connected with a lot of compassion. But when we are in the field caring for our patients, what are we really doing? So that's a big, are we compelled to do the care, or are we doing a compassionate care because we are in the field? So that's a big challenge. So over to Sashikala. She will be introducing the speakers, and followed by that, they will be taking over the session. Over to you, Sashikala.
Thank you, ma'am. I'm very much delighted to invite the speakers of today's live webinar. The first speaker is going to be Mrs. Saumya Anthony. She's working in High Dependency Unit, the Royal Brompton Hospital, London. Mrs. Saumya has completed her BSc program in CMC at 2005, and she has got her MSc Nursing completed in Triple M College of Nursing in the year of 2017. And she also has some additional qualification with PG Diploma in Hospital Management in Madurai Kamaraj University. Mrs. Saumya is a registered nurse with over 15 years of dedicated experience across the wide range of duties as staff nurse, clinical instructor, and quality manager. And she's exceptionally well in skill in all the facets of patient's assessment, communication, and delivering the highest level of patient care. Currently, Mrs. Saumya works as a critical care nurse in high dependency unit, where she handles and cares the patients with COVID-19. It's very delighted, and we are very happy to invite Mrs. Saumya for this live webinar. We are very eager to hear you, Mrs. Saumya, and this is our e-bouquet we would like to give on behalf of Triple M College of Nursing. Kindly accept this e-bouquet.
Thank you. Thank you.
Okay, e-bouquet, it will be delivered soon. Due to technology, it comes little slow, I believe. It will come. Yeah, is that fine?
Thank you for the e-bouquet.
Thank you very much. Next speaker. I'd like to introduce Selma Thomas. Madam is working as a deputy nursing superintendent in Sri Ramachandra Medical College. I mean, Swami Ramachandra Hospital. 1 minute. The slide has not been projected.
The orange.
Yeah. Sorry for the delay. Second speaker is going to be Mrs. Salma Thomas. Ma'am is working as a deputy nursing superintendent, IP operations, Sri Ramachandra Hospital. Ma'am has held various positions as chief nursing officer, NABH assessor in Quality Council of India, senior nursing educator, associate professor, honorary senior tutor, a cardiothoracic nurse and tutor. And also, ma'am has secured with various academic excellence like NABH assessor course in Quality Council of India, certification in concurrent review, certification in clinical counseling, certification in essential of palliative care from Indian Association of Palliative Care, where ma'am had a best case presentation. And ma'am has completed her UG and PG in CMC Vellore. Ma'am came out with a best clinical nurse award. And ma'am was also having an additional qualification of MA Psychology from Annamalai University, Chidambaram. Ma'am currently pursuing her PhD in nursing in Tamil Nadu MGR Medical University, Chennai, and also Executive Diploma in Healthcare Management in Dialogue Institute of Business Administration. Ma'am holds life membership in various professional organizations like TNAI and Nursing League and CMAI. And ma'am also held examinership in various universities as an examiner. And ma'am has got wide experience in multifaceted area of academic, administrative, quality control responsibilities, and specialized in telemedicine and outreach activities, and also in clinical and geriatric counseling, and much specialized and very much interested in arts and sculpture and dressing making too. Ma'am, we are on behalf of Fundamentals of Nursing Department of MMM College of Nursing. We are very much delighted and happy to invite you for this live webinar.
Thank you.
We'd like to give you an
Thank
e-book.
you.
Kindly accept this, ma'am.
Yeah, sure. Thank you. Received.
Information before we start the live webinar. Kindly put all your mic under mute, and if you have any queries, you can put your queries in the chat box. At the end of the webinar, the speakers will be clarifying your doubts. And second one, you will get a feedback link at the end of the webinar. Kindly fill the feedback link in order to get your e-certificates. Thank you very much for your cooperation. Now we'll start up with the first session. Mrs. Soumya, our speaker from UK, will take over the session. Thank you. Mrs. Soumya?
Yep. Thank you, ma'am. Can I have the first slide, please? Can I have the first slide? Oh, yeah. It's just another day at work. I have infusions to prepare, antibiotics to give, bloods to be sent, notes to complete, patients to be rolled, sheets to be changed. The ventilators bleep, the alarms blare, and the filters whir. In midst of all this, I hear something. I hear a conversation. I dare not look back. I hear a daughter pleading. Dad says, "Stay strong." I hear his wife's wail. The daughter pleads for her dad to fight. I hear the helplessness. I hear fear. I hear agony, heart-wrenching cries. Silent tears drip down my mask and splatter on my gloves. I blink to clear these tears. I cannot touch my face to wipe them. I peer into my face shield through blurry eyes. Those cries will ring in my ears throughout a lifetime. I turn around to look at my colleague. In midst of this chaotic turmoil, she stands strong and stoic. She stands there holding back tears. In one hand, she firmly holds the phone, with the other his frail hand, a silent witness to a final farewell. I can see her crumbling inside, emotionally weakened and traumatized. Yet she stands, and she stands strong. It's just another day at work. Good morning, everybody. I'm Soumya. I work, and I thank Shashikala ma'am for those kind words of introduction. I'm a nurse, and during this entire pandemic, this was one of the poems that I wrote to ventilate my emotions. I work in the Elizabeth HDU, and it went on to become an Elizabeth ICU within a matter of a week. So that picture there that you see is my entire unit, and that little blob of yellow you see is me. Next slide, please. Next slide, please. Yeah. So COVID was happening somewhere far away in a country that doesn't bother me. Something always happens in China. There was a widespread apathy that it's not going to affect me or us in any way. But when it hit us, the major thing, there were a lot of things that happened before we actually got the pandemic, but the majority of it, I can put it under one big umbrella, is fear of unknown. We did not know what was going to happen, how we were going to cope, what sort of disease it is, how badly is everything going to change. There were a lot of queries, and that just changed the entire dynamics of being able to face a stressful situation, because you have no idea what is in store for us. Most of us in our HDU are used to taking care of level 1 or level 2 patients who needed that amount of level, who are in day 3 or day 4 after surgery. They're pretty ambulatory. So suddenly you're asked to take care of level 3 patients who are on ventilators, large amount of inotropes, very bad gas exchange, and who have collapsed all of a sudden. So that took a huge toll on us, because we did not have the skill nor the knowledge to take care of them. Entire world situation was dynamically changing. We had no idea where everything was going to come from, because in UK we're dependent on imports to a large extent from other countries, and all of that was going to change. Every day-to-day survival was a question. The picture that you see, the top is the one how my normal journey to work looks every day during the pre-COVID times. That's how my journey looked like, pretty rushed. I go to Central London, and it's one of the busiest underground stations. But the day I started my shift after this COVID pandemic, the train looked like that for almost an hour. So it was very scary. Just it hit me when I was going to work that is going to be the new normal. Suddenly there are no people around, and the only people going to work would be nurses, doctors, or essential workers. So it just hit very strongly and suddenly that how alone we are when we face one of these situations. Next slide, please. Next slide, please. So how did we deal with this? We were trained, and the training was very intense in a very short amount of time, and the learning curve was really steep. A typical ICU course, somebody who works in a level 2 or level 1 typically needs 6 months intense training in an ICU to be taking care of level 3 patients. We had just a week to prepare ourselves for it. So you can imagine the amount of information that was loaded into us. Taking care of a patient on continuous renal replacement therapy or a dialysis unit, mobile dialysis unit, takes 3 weeks. We had 3 hours. A ventilator patient, taking care of everything about a ventilated patient, takes 6 weeks. We had almost 3 hours again. That's like, it was divided into, there was so much information that was funneled down to us in a very short amount of time that it actually did not make sense, and it made us really, really scared. But there were some bits and pieces of information that were retained that really helped later on. But there was a very fast influx of information. And we formed teams, which is the best part of the training, because we had people coming in from the outpatient, because the outpatient department was closed, operation theaters were closed, cath lab was closed. The cath lab was closed. We had a lot of people who were not who were skilled in very specific things like OPD, but we could not use them in an ICU. So we formed teams. Teams, like for example, a person, cath lab and OT are excellent people for turning a patient, or they have skills in efficiently, rolling a patient, changing sheets. So we had teams like rolling teams. We had teams for proning the patient. We had teams who did ECG. We had teams who did sheet changes. So all our work that could be allocated to another person was deputed in such a way that that team would come and just swoop in and do it. So these teams were trained during the training, and our basic nursing skill set was again reviewed, because ultimately you might give excellent ventilator care, but if you don't give a proper mouth care, you're going to cause a VAP to the patient, and the entire thing would just go. So the unit realized that we needed to have more of this initial training, the basics of it, like your eye care, mouth care, how you organize, how you make your time plans. All these were reviewed again, which made a lot of difference when we started actually taking care of our patients. Next slide. Thank you. I have grouped the challenges, like I went around and asked my colleagues, like we are 60 of us, and I talked to at least 20 of them, and I understood like all the challenges that we all face, and I grouped them as manpower, health risk, and material management, and ethical problems. So many of these things, which I'm sure you already know about this, but this is from my perspective, and I would also be dealing of how we were able to face these challenges and some new learnings that we did, which could be useful for us back home. So manpower wise, so the main problem that we all faced was a skill mix. Like I told you, we were a group of people who are trained in a very short amount of time, and our training was not validated, and we were not competent enough. So we actually the skill mix was like, for every 2 nurses who are taking care of, who are HDU nurses, there will be at least 1 nurse who would be an ICU nurse, which was okay in the initial bit. And then we started getting loads of patients inside that the ICU nurses had to take the patient as well. So it was very unfair of me as a HDU nurse to ask an ICU nurse to help while she herself is struggling. So this skill mix got really mixed up. There was this huge tax on both the ICU nurses as well as me, who was undertrained. So this skill mix had to, it was a very delicate balance there. Clinical expertise was a question, because COVID-19 was a dynamic disease. It was changing every day, and what China faced was not what Italy saw. And what Italy saw, we were just coming after Spain and Italy. So we most of our clinical team is either from Spain, Portugal, or Italy. So they had very good contacts with the clinical teams in Italy, but that was not how the virus was reacting in the UK. We had a much more intense and much more widespread, because of our lockdown measures were not in place until the last minute. So we had quite a huge influx in a very small amount of time, and it was concentrated around London. So overnight, my hospital went from a specialized cardiothoracic hospital to an exclusively COVID hospital. So we started taking an influx of whenever the ventilator beds in my nearby hospital finished, the next ventilated patient came to us. So all our expertise in our hospital are used to taking care of cardiothoracic patients, and suddenly they're dealing with respiratory as well. So that was a huge issue, and it was a dynamically changing situation because we never knew what to expect with it. Patients were getting very anticoagulated. We were not able to wean them off the ventilators. So, and tracheostomy was something very, very new in the hospital. So the clinical expertise at this was still at question because they are also learning. There was a time constraint for learning because you had to upskill, and you had to upskill really fast. And there were a lot of staff who went on, who got sick. And if you get sick, you are on 7 days isolation, or you could be in quarantine for 14 days isolation because you have somebody in your house has developed symptoms. You'll be on 14 days quarantine. Or there could be staff who are shielding, say staff who have asthma, staff who are pregnant from after 12 weeks. So all of them need to be given a major chunk of leave. So already we are running short on nurses. On top of that, there are many more nurses who are not coming to work. So there was a huge strain, and for the first time we were asked to do a lot of extra shifts, like people really asking us to do extra shifts. And on top of it, you're already tired. You have a lot of new people coming in, a lot of new equipment coming to a ward that you already know where things are. So there was a very, very high chance of error. A lot of errors. For a simple thing, for example, we use different dipsticks to check for ketones and for urine analysis. They look very similar, but as a HTU nurse, I know where they are kept, and I'm very sure that that's where I'll go and take this. But a person who's coming in from the OPD and helping me out will not know where to do that. So the error management was very, very high because you're already constrained for time. On top of that, you're new to the area, and there are a lot of equipment you're not. So the error management was, and motivation was a huge factor because every day, normally in a unit, we see they come in for surgery, they get intubated, they get extubated, we walk them, they walk around, brains come out, and they smile, they say thank you, and then you're done with it. There's a closure to it. But with COVID patients, there was no closure for us because they were getting worse and worse and worse by the day. And you expect to see results. Like you do take a care, you give care today, you come back tomorrow, you need to see a change for you to motivate yourself to do that. That was not there. So that was a huge factor. Next slide, please. Next slide, please. Yeah. Then the major thing was what was the risk for us? Obvious, getting COVID. Unlike what the statistics says, like we had our major chunk of patients came between the age of 45 to 60. They were not older than that. Most of them had fever for 7 days, breathlessness on the 7th day. On the way to the hospital, many of them collapsed and were intubated. That could just, you look at that and you think that could be me. You know, I could very well be lying there intubated, and when, you know, so that was very scary. The chance of you actually getting infected, you know, and everybody's on ventilators. There are a lot of aerosols generating, and how far can you protect yourself? That was always a question. It was a huge health risk. When you're in PPE, I'm sure everybody knows this, that you sweat a lot inside the plastic, and that just kind of sticks in, and you're not drinking water as much as you did. So obviously dehydration, and because of all of the PPE and you get dermatological issues, permanent scars behind the ears and on the nape of the neck, on the bridge of your nose. Extremely painful because you keep going for the shift the other day and it keeps rubbing on the same place. You don't drink enough water, you develop UTI. Most of my colleagues we all developed UTIs, but I'll tell you of some of the things that we did to prevent that. Another thing is claustrophobia. When you're in a mask and then a shield and then goggles and inside an enclosed environment, you tend to feel claustrophobic. And even if you have never been claustrophobic, trust me, you will start developing feelings of claustrophobia. And depression was another major issue that many of my colleagues faced with, because probably because of the support system here is, the social support system here is not so great, but still, just the fact that everything is changing and it doesn't seem to end, that caused depression. And lethargy was something that just weirdly came up again and again. Lethargy, probably because we use a lot of adrenaline at work, and then once you finish your shift, you're just zonked out. Or it could also be because of the fact that this mask that you're facing is almost acting like a rebreather mask, because you're breathing in and out the carbon dioxide again. So there's very less oxygen going, and you're doing that for 14 hours in a long day. So that was, and the next day, if you're on off, you just are flat out. So extremely lethargic. Can I have the next slide, please? Next slide, please. Okay, so the challenges were in terms of material management. I think this is more of an administrative issue. Diminishing resources, stuff was vanishing. Suction catheters, tracheostomy tube, including paracetamol and aspirin that's supposed to be there in huge quantities. Everything was coming down because procurement issues were there. Things were not able to reach us in time, or they were getting slow because of various lockdowns everywhere. And there were security issues at one point. We were asked not to wear our IDs outside or show in any way that you're a nurse or a healthcare worker, because in underground stations and tubes, there were a few of the nurses who were mugged and their ID cards were taken. Apparently, people use these ID cards to get drugs or, to move around. So we were asked to walk in lighted paths. Because there are no people around and we are the only people walking around, we are likely to get mugged. So it was really unfair, but that really happened. And the entire world was changing. So getting stuff from into UK was really hard. So they had to change the protocols. Changing giving sets every 24 hours went to 48 hours because we were running short of giving sets. Pressure monitoring sets were every 48 hours again. So all these issues in the infection control thing, we had to compromise between having something and not having something, so that was a big issue. So they had to make choices and ask us to make the same choices. Next slide, please. This is a thing that came in, was the ethical needs and obligations. One of the major stuff that all of us said we faced was being with a patient when they were dying or getting this phone calls. All the beds that we had were ventilated patients, and there were people who fell sick very suddenly and their family were not allowed to visit. So I was wondering, like, the father is dying, he's gonna die in a day or two because it looks like that. And you're holding the phone the son is talking and you're holding the phone and you hear them cry because they cannot get there. They cannot see him. They saw him leave the house as a healthy man. Now they're seeing him ventilated and intubated on all the alarms bleeping, and they see this alien who's in all this thing taking care of his father, and they have they're helpless. That agony is something that we saw. We could not process it because you start mirroring it. So ethically, we give the patient preference, right? We tell, this is what we have, so would you like to do this? But in this situation, we could not tell the family those things. We had to make choices, and some of them were really hard and really cruel, like not allowing family to visit. They could not say their last byes. They could not say goodbye for the last time, and I was facilitating that, and that just did not seem fair at all. I had very less resources, and we had to distribute them among the load that's coming. So who gets to go on ECMO? Our hospital is one of the hospitals in UK that gives out ECMO, and it's a very specialized and a
pretty last resort for patients on ventilator. So we started getting calls all over UK so that our retrieval ambulance will go and pick them up. People calling and begging our consultants to please take their father or their mother. So these consultants, at least not me, the medical team had to make these choices of who would get preferential treatment. They had to make a choice, and I'm sure that will always weigh on your heart whether you did the right choice or not. So there was always the difference between what we should do and what we can do. That was really hard for many of us to get to comprehend and to process. Next slide, please. Okay, so this is what we did and how we faced it. How we faced it and how did we deal with it. So everybody was in the same boat. And this boat was moving very fast and very quickly. And at one point, it did feel like the Titanic, like the entire sinking boat. Just to realize that everybody's stents made a big issue, made a big relief that it's okay that everybody is still learning this. PPE related injury. So whenever we raised these issues to our manager, the manager immediately took it to the management. So when we came up with this issue where people started developing rashes, we don't have a dermatology unit. So our nearby hospital dermatology unit was called in for a consultation, and they came up with so in the donning stations, to deal with the dehydration, just before you don, there would be lots of bottles of water, and you could write your name on it, drink water, don, and then go off, and you can have a bottle at the doffing station. So you would ensure that whenever you don and you doff, you're at least drinking a good amount of water before you don, so that when you go in and when you put this mask, you start mouth breathing without your knowledge, and you wouldn't be so dehydrated. For the dermatology, they came up with the deoderms at the donning station. So before you don, you can put the deoderms on your nose and at the back of your neck, wherever you have, and take that off when you're doffing again. And because it's a deoderm, it's not going to peel and cause more injury. Many people told me that how I dealt with claustrophobia at one point is I'm not normally claustrophobic, but at one of the times I donned, I pinched my nasal bridge a bit too tight. So by the time I donned in and went inside, I realized it's too tight and my nose was squished and I could not breathe. I could not breathe, and I knew that I don't have time to doff, and that's going to take a solid 20 minutes, and 20 minutes is a luxury. So what I did was I knew that I would just collapse and if I don't do it. So I went to a corner, closed my eyes, and thought of my happy place. I thought of the face of my most favorite person in the world, and I just calmed myself down. Just be mindful of the 5 senses, like your deep breathing and closing the eyes and just consciously calming the self down. So I had to do that a couple of times before I doffed off for the next, I think it took me another 3 hours to doff. But during those times, I know that it's very claustrophobic, and many people feel that you get this thought and it runs in a loop. Like that's how you feel just before you die. Probably you'll die without getting breath. So it's very scary. So you have to find your own way to deal with that claustrophobia. Upskilling. Upskilling was quite new to us. Like very quickly you're learning, but I learned to take one thing one day at a time. So if I did something like patient had an arrest and I froze on my long journey back home on the train, I sit there and even though it's embarrassing, I relive the situation, erase it and rethink how I would do it and go home and read about what I did. No matter how tired I was, I came back home and I read about what I did, some medicine I did not know or some technique I did not know. Just even 5 minutes, it made a lot of difference. So the knowledge curve just went steeply high. There was a huge rumor going around about a PPE crisis, that we won't get PPE, you will have to reuse your PPE. There was a crisis, but how the management dealt it was really amazing. They got we have a school nearby, the London Institute of Fashion. they had a lot of designing students who were learning designing. So they asked them to volunteer, and they took the OT drapes and they made all the OT drapes into gowns, and they made them stitch scrubs for us, and they made us stitch disposable masks for us, which we could do outside the COVID area. So they used the resources that were available. There was a news overload. Any person you talk to will always talk only about COVID and how negative it is, and how, so trying to see that the silver lining around the cloud was really difficult, but I did it by avoiding anything about the news. So I just didn't really bother about the news. Family, we stayed away. There are colleagues of mine who stayed away for almost 4 months because they had elderly parents at home. We had, each of us, at least we developed a clean pathway to our home, where we would come home, take a shower, and then get into the house, or, keep our hospital stuff away from the home, all those particular things. And last thing is an interprofessional conflict. When you're completely dawn deaf, you don't realize that a lot of our communication happens to our face. I might say things, but my face makes a lot of difference. When you can see my face, there is a difference that that I'm actually a kind person. I'm not as rude as I sound. So you have to take an extra effort to have more verbal communication. Use more P's and more T's. P stands for please and T stands for thank you. Say please for everything and thank you for every single thing. It makes a lot of difference. It diffuses the tension. People got really lonely during COVID. Start a WhatsApp group, and we talk about, ventilate it, at least among the colleagues, of what happened. Next slide, please. So burnout was very huge because we were literally burning out like candles. A lot of pressure everywhere. So analyze ethically what you did, what you could do. Even though you're part of a multidisciplinary team and you did what everybody decided you do, but you were the person who was implementing it. But still analyze it and see, having a very good awareness of the internal dialogue. The mind voice that we have that keeps talking to us always. I realized that mind voice needs to be regulated. Otherwise, we could just go down. You could get depressed just overthinking things. Mindfulness is being aware of the situation, like be aware of the right now. Live in the moment is mindfulness. During the pandemic, we were always thinking of what the future will be, how will it be. Just live the moment, and that moment went away, the next moment came. Our hospital did something amazing for us that really motivated many people, and it is the British Airways launch that you can see there. That is just in collaboration with the British Airways. When we go to the airport, there will be a lounge and you can just sit there and relax and wait for your flight. They give you first class services. The British Airways arranged something like that in our hospital. They changed an entire seminar room into a lounge with relaxing chairs and good coffee. On the LCD projector, they projected a video of a beach where the waves were crashing. The stereos were arranged with the noise. So the ambience felt like you're at the beach side. So you get when you have a break for 15 minutes, and those 15 minutes you just sit there with a cup of coffee. It felt like we took a vacation, and it felt like it was a tiny gesture from them, but it just felt so warm that somebody actually took an effort to give you a small little happiness in this dark place. So that was something very nice that they did for us. We wrote. Many people who have never even written a diary started writing diaries, and people like me started writing poems, which we dig up when the time needs. It really helps to put into paper what you actually feel. Later on, when you look at it, when I look at that poem, I would think, was it so intense? Did I feel it that way? So, right? Or sometimes you can even TikTok what you feel. So, next slide, please. So the new learnings that we did, the new learnings is, if you ask me to go and do a job, I might just do it. But if you say I'm a superhero and go and do the job, I might do it really well. So when they had this thing in UK here for a couple of months when the COVID was going on, that every Thursday at 7 o'clock, they would come out and clap for 5 minutes. So that would be the time I'm finishing the shift. So after a really bad shift and I'm walking down the road towards my home and people come out and clap, you just feel like crying. At the same time, you hold your head higher and, stand a little stronger, and you feel like, yes, I'm a nurse and I'm proud of it. You're clapping for me, thank you. And it just felt really, really nice. Wherever you go, people are clapping. So you make something normal into being a warrior, people will do. We learned something about proning. Proning is where you take a ventilated patient and you turn them upside down. It's very good with ARDS. Oxygenation's improved drastically, but having a ventilated patient upside down is an extremely talented skill. You need 8 people. That's why I told you we had teams who were actually good at trained to prone a patient. So nursing a patient in a prone position was amazing. We had so the key to dealing with all of this in the pandemic was having Microsoft Teams. I think I'm running a little bit late. Can I have 5 more minutes? I can wrap this up.
Yes, Soumya.
Is it okay if I continue for 5 more minutes?
Yeah, no issue. Continue.
Oh, thank you. Okay. So Microsoft, so digitalization was the key to the entire thing, because we learned this about Microsoft Teams, where you can see the picture there, that in the lower left corner, where you see that we had webcams at every bedside. So when the team had to come, like the doctor, consultant, whoever had to come, they did not have to waste the PPE to come and just assess the patient. I would be at the bedside and they could use the Microsoft Teams to look at what the patient and converse with me, and everything is online. So saved a lot of PPE, and a lot of people could be involved in the care of the patient. So that was something amazing. I saw the art of redeployment. You have a lot of staff, and in one place, a major chunk like operation theater, cath lab, who are specialized, but that services are stopped right now. And you have some place where is in dire need of staff. So how do you redeploy them? Like I told before, OT teams are really good at changing, good at moving patients, lifting patients, manual handling. So they were changed into teams, and family involvement was amazing, because like I told you, it felt so unfair, and there was a lot of injustice in not allowing a family member to visit. So one of the things we saw was like every bay was equipped with a phone, an iPhone, where the family could FaceTime, and even if they're on a ventilator, they could still look at the patient, and they would be able to communicate and still be part of their care, which was very important. And the next one was liaison. I truly understood that when we learn in fundamentals of learning, you see the roles of a nurse and they say you're a liaison. To be truly the voice of somebody who has no voice at that point is really a blessing. A collage on the wall is, so you have a patient who is ventilated, and their entire face change, it swells up, and you don't really see the person, you see your patient. A collage on the wall is a liaison is also when you talk to the family and you understand the likes and dislikes of the patient. What kind of music did he like? What did he like talking to? Because you're the voice that he can hear. So you play that music. And they also send pictures to you over Microsoft Teams. So you can take printouts of them in colors and put them on the wall opposite to the patient. So when he opens his eyes, he looks at familiar faces. He would know where he is, but he would look at that. For me personally, when I was taking care and I'm rushing through a lot of stuff that I had to do through the day, just looking at the wall will humanize me, that I realized that he is just not Mr. So-and-so. He was also a father. He was also, look at his grandchild, look at his daughters. He's at his daughter's wedding. Those pictures really humanized everything for me, made me more humble, made me more mindful of what I was doing. And when you're in a PP, you're a complete alien. So there's this picture of people who came up with this thing, like you take a big printout and laminate of your smiling face and stick it on your PP and say, this is not me, but that thing on that ID, that's me. So it makes a lot of difference when people can actually picture you behind that mask. Then we had, so everything we learned was very, very quick. So all the guidelines, everything was quite muddled up. If you go to the next slide, you can see that this is the thing where, say, for example, NG tube, NG feeds. There is a protocol on how you start NG feeds. The protocol is definitely there in your protocol or forms on your system, but you don't have the time to log in and see and read that. You need something at that moment. Can I have the next slide, please? Next slide, please. Yeah, so if you have a look at that, that's how it was a very simple thing for them to do. Same thing, take the printout, laminate it, and hang it. Hang it very tightly close to the NG feed, to the giving machine, and then you know what you're doing. So these simple things, like they made the guidelines very simple. Like number 1, you do this. Number 2, you do this. Next step, 3, you do this. Nothing complicated, just simplified to the basic. It helped a lot with the error management. We also learned that small things make a mighty, mighty difference. Like you have inotropic agents running like a huge Christmas tree. I had this one friend of mine who told me that her noradrenaline was running down, and she did not know that the pressure on the syringe pump was rising, and they rolled the patient, and it was rising because probably it was kinked somewhere and they did not know, and when they rolled it, it unkinked, and there was an entire rush. So knowing these small little things makes a mighty difference for your day and for your patient. So these were some of the new learnings that we did. Can I have the next slide? And I think I'm done. Yeah, so there are 3 powers that I understood are very much intrinsic to this entire challenge that we face. The power of faith, the power of music, and the power of human resilience. Power of faith, having faith that this is not all in my control and there is a higher being, helped me to ground myself, to be mindful of what I was, and to count my blessings. The power of music, because you don't say they're in a trance, they're sedated, and there's a lot of stuff happening. The only thing many of them related to was music. I had an old gentleman who was 65 years old, completely disoriented and confused and agitated. When I talked on the phone to the son, he said he liked old Bollywood music. And I actually played old Bollywood music on the YouTube in the room, and he calmed down. He calmed down and he started tapping his fingers. He was really enjoying it, and music can really calm. So it's a very simple thing to do, but it was very intense and very, very new to me. The picture that you see there on the top is Sam. There is a story of him on our hospital website, Sam's Going Home. It's a very emotional story because Sam was one of our longest patients who has been in ICU. He got rehabilitated and he was leaving home. And Sam's story is really nice. And the thing that you were part of Sam, taking care of Sam even for one day, it would bring a smile to your face to see him go home. And it's a simple thing, he's going home, but to see his journey of from where to where he is gone. So humans can, no matter how many times they drop down, they can always pick up. You remember the poem that I wrote about? That initial poem that I wrote was about a guy. He had 3 arrests. So I think he had 4 arrests during the night, and this was in the morning. The daughter was calling and telling him, "Dad, don't give up," and the wife was crying. After this person actually survived, he was, at one point, he bled from every orifice that was there. He was an RRT. Nobody thought he would survive, but he did. So there's something beautiful about human resilience, that no matter how down people go, they will always come up. Most of them do. This picture down that you see, it was painted on the road. You are the real heroes. NHS, thank you. NHS is a National Health Service and we are all part of it. But something, instead of graffiti, you see this writ on the path that you walk right outside the hospital. Somebody had spray painted this overnight, and it's so nice to see all of these small little things that were happening, and small little gestures that people do. So nurses are really some of the superheroes of the healthcare system. I strongly believe that. Next slide, please. Next slide, please. Yeah. So what does the future hold, or what are we have discharged our last COVID patient, and this is how our future is. Like, our ICU is now into a COVID protected area. So the entire scenario is going to change. What is the new normal? We have to adapt to the new normal, because it's not going to back like the normal that we knew. We have to adjust, adapt, and survive the new normal. If the new normal is going to be something where you're going to nurse patients in PP, you have to do it. So the future is going to be, I don't know what the future holds, but I know who holds the future. So there is going to be a second wave. There are rumors of it in Europe, but I just know that whatever happens, that the second wave, we made a few mistakes back in the first wave. We will not make the same mistakes, but we might make new mistakes, and we will learn from them, and we would be better people. And yeah, next slide, please. Next slide. So that's it. I'm open to questions, and I thank MMM College of Nursing for giving me this nice opportunity, because I think this is part of my way in which I process my emotions. It really helped me to talk. So thank you for giving me an opportunity to ventilate and share these things with you all. And I think I've crossed quite a bit of time, so I don't think I have time for questions. But however, you could email me the questions or give me the questions in the link. I'd be happy to answer them. Thank you.
Thank you, Soumya. You have reflected the real scenario of what every nurse is encountering during this pandemic period.
Hello.
Thank you so much. Now we'll have a second speaker will be sharing with us on the topic, Equip and Protect Professionalism, a Top Priority. I invite Mrs. Salma Thomas, ma'am, to take over.
Good evening, all. I hope I'm audible at the other end.
Yes, ma'am.
Okay. So I was really impressed with Soumya. Soumya, I've seen her as an undergraduate, and she was always poetic. And I was so happy to listen to her poem, and it takes me back to my CMC days. But I've seen her as a young nurse, really, as a student nurse at the time, and it was really, the poem really touched my heart and it warmed it. I'm so happy about it. And Soumya, that was a wonderful presentation, and really, I could feel one with you. Okay, COVID. Now as a nurse, I won't say I'm just an administrator, because I find it a real pride in calling myself a nurse in the first place, because what we cannot do, we shouldn't be expecting others. Right? So I don't want the COVID care for the nurse, from the nurses to the patient, as a compulsion. It should come from our heart, because today someone is on the bed, tomorrow it may be me or someone else. One of us may be there as patients. So it is really important that the nurses are having the compassion for the profession and in taking care of the patients. And for a nurse to be taking care of a patient who is COVID positive and who knows that at any point in time she or he may be the next person with the same illness requires a lot of energy, a lot of inner energy, a lot of guts for it. Next slide, please. Okay, so when we're talking about a professional, so do we take it as a profession? So in that case, so what do we think? This is a usual lecture on what we think is the quality of a professional as a nurse. When we're taking care of a patient, first thing is we need to have an expertise in care, an expertise in the condition, an expertise in the in taking care of the patient in all their ways of life, because they're going to be lonely, they're going to be alone, no one else is going to be there, no attenders there, they're the only person with them. So there should be extreme expertise, and they must be competent, there must be honesty in it, and honesty in the sense sometimes we overestimate ourselves, sometimes we underestimate ourselves, a right estimation of ourselves. And the next thing is, when they are getting inside, there is always that there is no supervision, right? So that Hawthorne effect of when there is supervision, a different kind of care, and without supervision, a different kind of care. So we should be honest with ourselves. There is not going to be a supervisor. We have to be with ultimate integrity taking care of patients. When we've missed something, when we are doing something, when we haven't done something, whom are we responsible? Whom are we accountable to? It is to ourselves. So that honesty is ultimate here. And of course, it is out of, and not every nurse is actually willing to give the care. So they must be paid for their expertise. And the work, of course, must be very, very ethical in this pandemic situation. And we are not going to be judging them. We are not going to be evaluating them. It's all in our own hands, in our own integrity, to be ethical in the care that we provide. And in a situation where it's critical and you require someone to come inside and help, at that time, a person to dawn and get inside and help may take a minimum of 20 minutes. So they must have the critical thinking abilities, and they must be able to take an autonomous decision in saving the patient. And they must be able to, and one more thing is the emotional factor. And it is very, very difficult for us to be emotionally neutral when we're taking care of these patients. It really hurts us, and most of the time we identify ourselves with them, and most of the time we tend to feel like one of my patients was a young middle-aged person, but only thing similar to him and me, where both of us had a bronchial asthma and both of us were obese. Right? So I saw this young fellow die, and he was put in a body bag, and they were shifting him because the body bag he did not fit into. So 2 body bags, 3 body bags, they covered completely, and they were shifting him into the ambulance. And 8 people together had to carry him and take him inside. And when I was saying that, I was thinking probably that would be the same if I was ill too. So most often that emotional neutrality becomes an issue as a professional there. You will find couples admitted, the husband dead, the wife dying, and the wife doesn't know that the husband is dead. And you will find relatives coming, but they will not be able to see them. They will have to take them to the cremation ground straight away. So all this, are we ready as a professional? We can call ourselves a professional, but there is a heaviness to it when we call ourselves professionals and take care of the COVID patients. Next slide, please. Okay, when we're equipping the professionalism in us, what we have to do is, the first thing is to take the right process. So when you're talking about the right process, what we had to do was, pandemic is something that our generation has never seen. And it's a big learning. Every step was actually evolving. So we will try something and we'll find that there is a breach in an infection control practice. Then we'll try another one and we'll make sure that infection control breach is settled. And we had to make sure things are unidirectional. And getting that infection control practice into the heads of people who are at the ground level was another tricky affair, because we are always used to a very simple living. So when we make things very stringent and a small breach is going to affect not only me, but also others with me, we'll have to be extra careful. So the right processes had to be put in place. We had to start a fever clinic and then the ward for the mild and the moderate symptomatics. And then we had to step up into the ICU because a lot of patients who required ICU care were coming in, and suddenly a 1,600 bedded hospital was down to a 120 bedded hospital, and the 120 beds were occupied by COVID patients alone. And the 1,600 beds, we had sufficient staff. Actually speaking, we were comfortable with the nursing staffing, and suddenly we found ourselves understaffed. And one person gets affected, a whole lot quarantined. And one neighbor being affected, that area being a red zone, one whole lot quarantined. And suddenly we found that we did not have sufficient staff because the staff had to come, they had to do their duty. Management was very supportive in reducing their workload by 6 hours, 1 week, and 2 weeks of quarantine. And then it was reduced to 1 week of quarantine and 1 week of non-COVID duty before they were brought into the COVID area again. So we had to split the areas as sampling area, as a fever clinic, swab area, as ward, as HTU, as negative pressure zone, and ICU, COVID ICU. So we had to split the staff in such a way. We only found that they didn't have the right people at the right place. Especially in the ICU, there was a gross deficit. So recruiting the right people was the next thing. When the processes were put in place, we had to hunt for the right people. And ICU suddenly was not, it is a critical care ICU, but suddenly it is filled with the neonatal ICU nurse, the pediatric ICU nurse, the burns ICU nurse, the surgical ICU nurse, and the medical ICU nurse. And orientation to the area is different, orientation to the doctors is different, orientation to their own, the care is different. They had to be prepared to get in. And with the number of cases flooding, we really had to train a lot of youngsters and motivate them and encourage them to put them as, assisting the senior nurses for basic care. So that's how we had to introduce some right people. And after a couple of weeks of care, they were able to manage. And then motivating them was a very difficult task. And the younger nurses, we could easily, with a little bit of motivation, a persuasion, a coaxing, and, it was easy to put them in. But middle level, which was married, which had small children, very essential for taking care of patients, had motivated them, tell them it is not risky. Can we accept it? So at that point in time, all the leadership what? In spite of our own health conditions, at my age, most of them were diabetics. Most of them were actually asthmatics. Most of them had comorbidities. They're not fit to work in the COVID area. But what we had to do is we had to prepare ourselves, get ourselves into the COVID area and motivate them. So just to make them feel, yes, it is safe enough to work. And of course, the PPEs that was provided. Fortunately, we actually have a major in the army who is part of the PPE committee. And he makes sure it is actually the best of biowarfare PPE that is provided for us. And this biowarfare PPE is beautiful, it sounds, but once you're inside it, we're full of sweat. And, the number Chennai is being very, very humid, and especially in the month of May, when I get inside, I'll see all the floors full of water. And I often used to blame the housekeeping inside. Mop patient but the nurses inside will say, ma'am, it's not water, it is our sweat. It used to seep through the PP and flood the floor. And when they are doffing, we have to have a doffing buddy nurse there. When they are doffing, when they remove the PPE, you will find sweat pouring out of the PPE. So you can imagine the amount of dehydration they had to undergo. And with all that sweat, we never permitted them to drink water or anything inside, because that would be a breach in PP and that would cause breakout. And most of them being young and in the hostel, even one person getting infected is calamitous for the entire team in the hostel. So we had to really persuade them not to take anything during their 6 hours. And they had to be put on, right before their entry, they'll be given a lunch, they'll have to drink water, put on their PPE, we will have a check in front of the mirror, they'll have to check for themselves and then allow them inside. And after their doffing, we had to arrange special areas where we could give them they could have a bath, and they could change into the other clothes. And now where do they stay? Can we send them home? What is the assurance that we have that we can send them home in a safe manner? So what we had to do was we had to arrange 2 floors for their stay. So the nurses were staying within the hospital on 2 floors. On the right wing is having the patients, the left wing will have the nurses and the other healthcare workers staying. So food was arranged for them. The 1 week that they worked with us, they had to stay within the hospital and work. And they were feeling a little bored. So the food has to be better for them because it has to boost their immunity. We have to keep some TV there so that some amount of entertainment is given. And post their duty, we couldn't send them back to their hostel or home. We had to place them in a quarantine facility to watch them for 1 week. So a particular student hostel was selected, and in that they are still placed for 1 week of self-observation. And this recruiting the right people to do the right job was indeed a challenge, and motivating them frequently, because if one person gets infected, the rest of them are really shattered. So at that time, we really have to constantly meet them and encourage them. And rewards, yes, it was very much essential. So these nurses were actually given an allowance, a higher allowance for those in the ICU, and a similar allowance for those in the ward, and of different grade for those in the sampling area and the fever clinic. Because it all depended upon the hours of exposure, the closeness of the patient, and the number of patients they have taken care, and the percentage of COVID cases that they have seen. And in between, now what happened was we did get a lot of antenatals who came in and were tested positive. So can we send them back? So antenatal area had to be split up now into suspect and positive and a negative zone. So we had to have nurses where split into 3. So one will take 3 batches, and one will take care of the duty, one will be on quarantine, and one will be in the non-COVID area. And the person who is taking care of COVID area, they had to be made sure they are well taken care of, and their immunity is boosted, and they are encouraged. So now again, it comes back to the numbers. So again, there was a crunch on though we had enough numbers, when we had to divide them into different areas, numbers were reducing. But still, I would say it is purely by the grace of God, and management was extremely supportive, and the young nurses, they really pushed themselves, leveled up, and they really supported in every bit. And so their rewards they were definitely essential for them sufficiently. And them, what is bothering them? Is the workload high? Then we found that the documentation was very high because we were going for NABH. A lot of documentation was there. So with the help of a medical superintendent and the quality in charge, we were managing to reduce a lot of documentation. And once that was over, we had to find a way of MRD, medical record management. So for that, again, we had to find a way of storing it away and then making sure it is decontaminated, and then it is stored in the MRD. And then it was, again, during the survey, we found that when documentation was over, but during certain times when the admissions are very high, the nurses were not able to manage too many admissions at the same time. So what we had to do was, they had to take the admission, and with the double gloves and triple gloves, taking a sample and visualizing through the goggles and the visor was definitely difficult. So we created another area where their initial admission would be done. Then patients were brought in, they were checked, and the initial assessment done. They were triaged, and then their ECG taken, X-ray taken, if chest CT needed, CT thorax that was taken, and then all the initial nursing assessment, drug reconciliation, everything done, and they were transferred then into the ward according to the triaged acuity. That reduced the workload. So this is actually an evolving process. Every day is a new learning, but surveying their perception and their work experience actually created a lot of impact. And the young nurses and their inputs were really very, very important for taking us through every step. And we had to, people my generation will actually know of functional nursing. But people, the present generation will actually think of only team nursing. We were also practicing team nursing, but we had to teach them functional nursing and team nursing so that they will be able to manage. Because when there was a delay in when they were coming out of the ICU or ward, the doffing area, most of the time they are dehydrated, their bladder is full, they weren't able to manage the extended time. So we really had to make sure the timings were just enough so that they will be able to relieve each other earlier and come out and make sure it is comfortable for each other. And so the engagement of teams, encouraging the teams to make sure that one person takes over, relieves the junior, and then they go. Or the next day, the other person takes over and they relieve the other person. So to keep each other comfortable. Next slide, please. Okay. But here, are we competent enough to take care of these patients? Initially, what happened was we'll just find nurses, even the donning was such a big issue. They really felt that donning and getting inside was a great effort. So they had to be trained with some PPE, just donning and doffing and sampling alone. And when they went inside, again, it was like donning, stepping inside. Now, what do I do? What should I do for the patient? Sometimes it just gives a block on your brains. How do I carry out? So they really had to reinstate by giving them in each shift. Now there are 4 shifts. In every shift, what exactly is their duty and what exactly is to be performed and how it is to be performed. So we had to retrain them. And one more thing is, the first batch that goes inside gave us a lot of input. The second and the third time when they went inside, they really... Hello? Okay.
Participants, kindly keep yourself muted so that you don't disturb the speaker. Kindly keep yourself muted, participants. Those who want to sleep, kindly switch off your cameras so that it won't disturb people. Thank you, Selma. Continue.
Thank you, ma'am. So I could see such a big difference when they came back again for the second time and the third time. They were kind of, COVID duty, paatharla, onnu prachana illa. Onnu illa ma'am, naanga vandirom. So that kind of energy they started having, because the first time was so difficult, second time and the third time they started getting used to it. And of course, they had to overcome a lot of personal barriers. For example, they'll each and go inside. As soon as they wear the N95 and stepped inside, they vomited inside the N95 itself. And we had to immediately doff and bring them out. And they had a lot of skin issues, then they have latex allergy. So we had to make sure a dermatology consultation was done and non-latex gloves was provided. And for a sweat, the only thing is that we cannot maintain an AC environment. So we had to provide a lot of fans. At times, I've noticed 3 or 4 nurses standing in front of a fan. But very unfortunately, the PP is level 5 PP. Even if you stand in front of the fan, you can only see the PP moving. You will not feel the breeze inside. But some amount of, at least visually, they felt that. And then there was a continuous on-the-job training. One thing is, for the wards, we had to equip them with basic cares. And in the ICU, we had to step up because we were having a shortage. We had to train the others and we had to mentor them with preceptor them and then put them inside along with the preceptor. And definitely this made, I can see a big difference in the children from the time they went the first time and the third and the fourth time. They got so used to the wearing of the PPE, the speed at which they wear and get inside, the speed at which they check themselves, and the speed at which they doff and they carefully move out. All that made a difference because initially there was so much of infection control breach. Of course, by the grace of God, they weren't infected, but still visually we could see that there was a breach. But all that was in the evolving process, it changed. And the mentoring definitely needed a change because we had to send the educators inside. Or every time when we teach someone, it always makes a difference when a person has experienced it and is teaching and a person is speaking from the theory. So we had to send the educators inside for themselves to be experienced. Even now, we actually post the educators in different areas to take care of patients. One is in the ICU, one is in the ward, and one is in the fever clinic. And 2 people are outside. So the 2 people who have already finished their turn inside, they teach. The ones who are inside, they actually take care of patients to make sure, they know what exactly is at the ground level. And so mental concerns, so based on their input, we had to simulate. And especially with the donning and doffing, the management supported us with, and the quality department supported us with the videos, quarantine posters, and also this vitamin supplementation for them. And this also we have the mentors themselves, the educators themselves, their knowledge had to be increased on the ground level reality and how to overcome it so that they could train the nurses. And initially there was a lot of, normally there is always a tiff between an educator and a nurse because they always feel that they are being overburdened by certain practices. But here we had to break that mold by the educators themselves going and working at the ground level and then educating the nurses. And this was quite a good experience for us. Next slide, please. Next slide, please.
Julian?
Okay. Protecting professionalism. Okay. So now when you have developed the professionalism and you know that we have to maintain it, and how do we do it? Now the challenges were not only in taking care of the patients and the patient's response also we have to see. How are the patients responding? Because now it's not a normal area. The girls are going in, the boys are going in with so much of fear. So always 6 feet away from the patient. So, and with all the PPE, let me tell you, I found it very difficult to see through the goggles and I found it very difficult to hear either. I used to go very close to people and ask them to speak into my ears. And then I used to, and now I learned a technique of making sure that my goggles are not fogging. And now I'm able to visualize better than the first time when I went. First time I really felt I was going to have a COPD and my chest would burst. but now I've got so used to it, I can stand it. So visual as well as hearing. Impairment is not with the patient, but with us. And patients feel that we are ignoring them. They'll call and someone will just keep walking on their own. So it really looks like the nurse is ignoring, but the truth is that she's not able to hear what person is calling. So every time we had to tell the patient, then she will gradually turn and then she will see that the patient is there. She'll walk back, she'll find out, go close to the patient, turn the ear towards them, and especially with the old patients, both ways we will have hearing deficit. So it used to be quite it's a funny challenge, but still every day we have to face it. And apart from that,
by that time you will get to free, means we will feel better.
But what happens is all the time, we have to tell them this is a COVID area, and the performance expectation is like in a non-COVID area, both from the patients as well as others. The challenges had to be overlooked, and or sometimes we had to emphasize on our challenges and make sure our voice is heard so that the other person understands that the nurses are undergoing a challenge. So that way, we really had to protect the nurses as well as encourage them. But very unfortunately, there was a small percentage who actually took benefit out of the challenges. So what they would do is they will just step inside, they will slowly huddle up in some area, because once you're in a PP, everybody looks similar, right? So what happens is they will huddle up in some corner where we'll never be able to find them. And that particular, and let me tell you, the mild patients, their acuity is very less. The maximum care that they would require is just their routine medication, their their temperature being checked, and their SpO2 being checked and monitored. They will not require anything more than that. Or regularly, they must be given their feed, and the diet has to be circumcised. The younger population, which is in the mild case, they often take care of themselves. So these people who are actually hiding out, they don't get caught. But in the moderate cases, we definitely have to extend a little more of care. So what we had to do was, we had to make sure patients were segregated according to acuity, and the number of patients were increased. For mild cases, and the number of patients for the moderate cases was, the patient-nurse ratio was reduced for the moderate and the high dependency area. So that actually improved the care. And one more thing is, after the segregation, the number of nurses, number of patients in one area of similar acuity was brought together, so that the nurse had to give similar care for them. So professionalism, it is commitment that is required for professionalism. So we may do a lot of benefits. We may be motivating them. We may be encouraging them. We may be, negotiating with the management to get a lot of things done. And we may be improving the processes. But at the end of the day, the commitment comes from within. The nurse, is she committed to the care? With what compassion she's doing, or is she doing it just for the sake of a job, or just for the sake of the allowance, or just for the sake of some benefits, or just for the sake of, I'm a nurse, I'm employed here and I have to do it. No, there must be a commitment, a compassion with which they have to give care. And that actually we have to personally talk to each one of them and build that commitment in them. That is an effort from the administrator. And new technology, because a lot of it is going online. And now when you have to fill a form, you have to make sure the ICMR form is filled, an SRF number is generated, the SRF number has to be enhanced so that when you're resampling and sending, there is no confusion on the same patient, and because the number has to be the same when you're resampling for the same patient. So all that, everything is being done online. So when it is being online, so many days we've been doing it on the document. So when it has to be transferred to online, now new training is required related to use of gadgets. And occupational health, right? So there is a definite concentration that we have to provide for the occupational health. at whatever cost. Patient and nurses or doctors or healthcare professionals, whoever is involved, the housekeeping personnel, nobody must be exposed to the infection. So I have to say, by the grace of God, we've had only 17 nurses infected, out of which only 6 were infected almost like 4 days into their quarantine, not during their work schedule. And the rest were actually community spread. So that cannot be counted as COVID duty spread. So post-COVID duty, 6 nurses were infected. Out of 6, it was actually the 4th day of quarantine that we recognized them with mild symptoms. And all of them have been discharged fine. And of course, with community spread, we did have quite a few nurses and their contacts, and the doctors, managers, administrators, whole lot of them. Because I think in a pandemic, nobody is spared. It's no difference. Pandemic is a pure communist that doesn't spare anybody. So they did have a collection, and everybody, of course, is scared, but we had to overcome fear and work. Next slide, please. Confidentiality. I do have a lot of my pictures. Every time we get a new PPE, the personal protective equipment, a coverall, we have to get a feedback from others. And apart from getting the feedback, I also try it on and go inside and stay at least for 3-4 hours to see how exactly that particular PPE feels and what kind of problems can occur. So most of the time, when I get inside, I take a photograph of myself. And when I was reading about confidentiality, most of us are excited to see ourselves in a new PPE. But what happens is, most of the time we forget about the background of the photograph. So I'm always scared. I may ignore which place I'm standing in. And next thing is, we should not be exposing the patients whom we are taking care of. That is one thing. So the confidentiality factor, because every day we are seeing patients, every day we may see many people, but their history is very, very confidential. We can, with certain restrictions, we can always share the cases, but we must make sure that their patients' confidentiality, they are lonely, they are alone, they are not having any attendants with them. At that time, they may share a lot of information. So we must be very, very careful with the confidentiality aspect. Next one. Next slide, please. Okay, so each of the nurses had to be adequately trained. Sometimes what happens is they are sent for VIP sampling. So we always tell them, you should never come back and divulge to whom you have taken sample. So to whom you have, who has been tested. So all that is confidential. So we have to adequately train them on keeping their mouth shut, and keeping our curiosity down. Because often what happens is we are curious to know what has happened. So we have to keep our curiosity down and keep the other person's mouth shut. And when you're releasing photos, we have to make sure the institution as well as our own identity or the patient's identity is not shown in it. And post as conditions, like so many patients, and statistics is okay, but not as cases. And it would be good when we are narrating in vague language, like yesterday at 3:30 p.m. At this particular patient in this particular bed number died of this particular complication. Instead of that, when you're presenting a case, it would be like later we had a patient with this particular condition. So that way, so that their identity is also kept under wraps. And anything, because now COVID cases, we may be trying a lot of medication. It's not that they are trying a lot of medication. There's a clinical governance council which actually permits medication that is administered to the patient only after rigorous literature review. And that committee actually takes care of all the literature review. Then they make sure a particular drug is initiated in the patients. And whatever it is, a written consent is required. And for whether you're talking about the patient or giving them a drug or any other purpose. Then, and most often the issue that I'm facing is these children, they take selfie and they post it on the Facebook. And people will come and ask me, how can you allow the nurses to take selfie and they put it on the Facebook? I seriously don't know how much we can control, because everybody is excited about, their work in spite of all the challenges. In spite of all the challenges, they're excited about work. And these are small things that they enjoy, putting their picture on the Facebook. And I've tried telling them, but not harsh enough, I suppose. And one more thing is, most of the time when we work with COVID, people get our advice. It'll be good if we don't give it on a public forum. Because it's just an evolving condition, evolving management. And in that space, we shouldn't be getting into any kind of a legal issue or when we are giving out some kind of a medical advice. Next slide, please. Next slide, please. Okay, as a professional, as a nurse, one thing is we may be doing a lot of things, but we should make sure what we're doing is actually visible. We should speak up what we are doing. Then we should take risks. Risk taking is important. Fine. So many people initially who refuse to get inside and take care of patients, now when they know that in their own household they are having COVID cases, their own neighbor is positive, their own colleague is positive, now they are taking risk. Okay, this is my life, this is the new way of living, and let me take the challenge. Now they're taking the risk and negotiate. So as professionals, we should be able to negotiate what we want. And one more thing is, as a licensed officer, between the patient and the doctor and their relatives, everything, there's a negotiation that is important as enablers. Right? So we should actually be able to show how much of work. It's not about others' recognition. It is about yourself being recognized for your own work. The next thing is, you should have a good network with people so that you are able to share the common knowledge and make sure, like Soumya was listening to Soumya was a big learning for me. It was, and one more thing is, they have already reached the peak. They're expecting a second peak. Have we reached the peak yet? So it was good. We may know a few things, others may know better things. So it is good to be along with someone, being mentored and mentoring others. But we should handhold each one of us. We have to hold each other and support each other. And of course, job opportunities is very, very important. That one thing is, what I found is, people who've been working in the COVID areas, they've gained so much of confidence in taking care of infectious diseases, in all the infection control protocols. That itself is a big plus for them. And people have to be upskilled periodically. It's an evolving disease. Every time there's a change, and none of us we are experts in it. So in that case, we are evolving, we are learning. At the same time, we have to go, make sure we are in time with what is the condition. And we should have adequate resources for ourselves. Next slide, please. Thank you. It is, let me tell you, it is a task encouraging and motivating people to work in COVID, because the risk is not only for us, but also in my family. Because let me tell you, when I come back home, I isolate myself. I don't stay with my children or my parents. I haven't visited them. So it really, I'm scared that I may be a carrier. Because a lot of doubts that comes to our mind. And day in and day out, we are seeing patients. Every time when I ask their history, each one gives a different history. At that time, we go through a lot of inner turmoil. Fine. So, but we still, as nurses, we have to take risk. It is impossible to live without failing. Of course, it's a trial and error. We will fail. We will have some errors done, but we have to get up and do it once again, because we are the warriors for taking care of patients. And if you're so cautiously living, let me tell you, Corona will be knocking at our doors. We have to face it. That is a reality. Okay. So I would like to thank each one of you for your patient listening. And I would like to thank Rosalind ma'am and Triple M for giving me this beautiful opportunity. Thank you. Are there any questions?
Thank you, Soumya and Salma, for that beautiful job of taking us through the journey as a staff nurse, as an administrator, what you go through. We have just read through literatures or papers or listened to so many WhatsApp messages, which may be true, may not be true. But, you have really taken us. So it was so much of activity where we, especially when Soumya was speaking, I know, your journey here in India and then a new place, venturing into the new place, and there it is the COVID unit. So literally we can feel from your shoes how you would have felt at that moment, because hearing
Thank
from
you.
outside, we have really not worked in the unit. And I'm sure the many of the participants here are also comfortably at home or at work and listening to the scenario, but you were there in the area. So hats off to you, those who are in the clinical field. I'm sure very less people will be connected in the clinical because they are all now fighting with our patients or helping our patients. So those who are here are, in fact, I can say 90% of the people would be comfortably only listening to stories or learning something, and still, the amount of fear when we get back home, those of us who are working, when we get back home, we always have a feeling that would we infect our family members? That's the fear we have. Then imagine when you take care of a corona patient and when you get back home and when you work in the unit, and especially like Selma delving into their PPE and checking whether, how comfortable are your staff nurses. That shows how much you have really cared for your staff nurses over there. Excellent job you have done, and this is ongoing. So as the speaker said, today it's some patient on the bed, and tomorrow it can be anyone from, all of us, we cannot escape from this situation, that we know that. So thank you so much for that lively presentation. And is it compulsion or compassion? So is something which is very challenging as a nurse. Right from day one, we have been learning about or we are teaching our students and our staff nurses to be giving a compassionate care and to be responsible for the and accountable for the responsibilities which is on their shoulder. But now, caring for a patient in an ICU is totally different from caring for a corona patient in the ICU, because you can be one. When we are caring for a patient in the ICU, it is a different scenario because you have protocols and you are doing your best to bring that person out of the particular ailment. But here what happens is you want to do that, but you are worried whether that is going to attack you. So our fear is mixed in the nursing care. And I'm sure it was the nurses. I can say it is 99.9% it was the nurses who faced the challenge for 24 hours, because I happened to listen to some of the nurses saying that, ma'am, they were just looking at us in the perspective of, as though we were patients. Our doctors were looking at us that we were, like a patient. They were looking at us and they were standing far and they said, would you give a mask for me? Only then I can enter in, or just leave your, leave your papers there and I will wear a glove. And then, they were looking at us when we asked for orders. And sometimes people were not there to really care for or to give us even the orders. And they were all comfortably seated in their rooms. And it is we who are fighting. And end of the day, there were some nurses who were not even paid. I'm happy that Salma was saying a special payment was there and some of them were not paid. I had so many phone calls and so many issues going on and around. So one thing I said, just forget about your payment right now. You are being rewarded. So my dear nurses and my nursing students and those whoever is connected, each one of us, either we have cared for or we have shared our knowledge with people, we have educated somebody. We have come into this profession not just by chance. It is not by chance. So nobody can escape this situation and run away because this has come. We have lots more to come. So once we have entered into the profession, we need to understand that this is a noble profession and God has given that ministry into your hand. So we have to somehow face the challenge and we have to fight this, and we need to be an angel to those who are in need of our care. So thank you so much. There are some questions. Any participants, would you like to unmute and ask any questions? You can do so that it will not be one way. And there is one question here. All the participants have appreciated your lively presentation. So on behalf of all the participants who are connected here, they have said excellent, lively, this is the need of the hour, and a lot of beautiful comments have come up. I appreciate both of you for taking them through the situation. Very informative, touching, practical. These are all the nice words they have told. There's some question. There's one question here. Shobha, would you like to raise that question? I missed out on that question. And if anybody who's not able to open the feedback, there are some comments saying that feedbacks cannot be opened. Is it so? Are you all able to fill in your
opening?
It's opening?
It's not opening.
It's not opening.
Yeah, just Sashikala, just check.
We checked, ma'am. It's opening. Please check your connectivities. Whoever is saying it is not opening, check your connectivity. It is opening. It is in active form only.
Again, repost the feedback. Okay, by then, any comments, any questions? Shobha had a question. Shobha, would you like to ask that question?
Yes, ma'am.
You had a question posted.
Yes, ma'am. Ma'am, I wanted to know what all the different measures are taken for us staff nurses who is there with comorbidity.
Okay. Were there staff nurses with comorbidity who were caring for COVID patient? What are some of the measures? That's the question. Selma, can you answer that? If any one of your nurses were diabetic, hypertensive.
Actually, we didn't post the nurses right away. We had to, yes, ma'am. So we actually did not post the nurses check. Fitness check comprised of the blood sugar levels, a chest X-ray, a preliminary WBC counts, and the blood parameters alone, and their history. So if they had any history related to lung infection or a bronchial asthma or bronchitis or tuberculosis on treatment, any of it we didn't take them on. And those with the blood sugars were checked, and if they were even remotely diabetic, we didn't take them initially. But what happened was, on the long run, when the nurses, they felt that it was safe enough to get inside. I do have a couple of nurses who are just in their 30s and they are diabetics. But what they did was, they said, ma'am, we'll be able to manage. And they started getting into the ICUs to support, because as I told you, ICU was already running short with not very competent nurses. At that time, these nurses, they said, no, ma'am, we will be able to manage. And they started getting inside, because we reduced the timings to 6 hours. We made sure they were getting the, most of the time, it is the 2 o'clock to 8 o'clock shift in the morning, early morning. That was very difficult for those with diabetes. So what we used to do was, we used to give them the 2 p.m. to 8 p.m. So they used to have their lunch and they used to come inside. And it wasn't the kind of time where the bladder used to get filled so easily also. So we used to give them convenient work timings also for that. And one more thing is, we did not put them inside right away, because 6 hours managing a PPE immediately was difficult. So what we did was, we put them in sampling area where they would wear the PPE for 1.5 to 2 hours. Then we put them in fever clinic where they would wear it for 3 to 4 hours. And then we used to put them in the ward where they had to manage for 6 hours. So step by step, it is like you just get warmed up and then get into a regular mode. And so this way, but we definitely withheld those on insulin and those with comorbidities. And especially, like one of them actually had tuberculosis treated some 3-4 years back, and she did have some, in the chest, in the X-ray film, there were some chest changes in the chest X-ray, but she was willing to enter. But what happened was, within the first 2-3 hours of entering, she felt suffocated. So what we did was, we told her, it's okay. We understand your intention to help, but still we'll keep you in the other areas where lesser care is required. So we put them in non-COVID areas and in areas where lesser exposure was happening.
Thank you, ma'am.
Thank you.
Thank you, Salma. Anybody else who want to ask any questions? No questions?
There is one question asked, ma'am.
Yeah.
What are all the measures being taken to reduce the stress of a nurse, one who works in the COVID area, COVID duty in the clinical side? Salma, ma'am.
What is the question? What is the question?
Stress relieving measures given for a staff nurse working in a COVID unit.
Ideally, it is extremely stressful. Okay, let me tell you, it is extremely stressful. By the time they come out of their, they are so dehydrated. When they come out, their energy is completely zapped. Even they have such severe body pain, and it's just, we say it's just 6 hours. But let me tell you that for just wearing the TP and staying inside and taking care of even the mild cases for 6 hours is difficult. And they come out, they feel so drained, and they have another 18 hours to recuperate. So what we did, the only things that we could help them with was making sure good food was provided. The management helped us with really good food, and it wasn't packaged food. It was served hot for them. That was one thing which helped. Next thing is, fortunately, the younger generation is glued to their cell phones. So when I go on rounds to meet them, all the time they'll be glued to the cell phone, only staring into their cell phones. But there was that little older population which wasn't glued to the cell phone. So we made sure television was provided in different areas. So that was one thing which used to keep them, it's just not the nurses, it's also the housekeeping that we have to take care of, the technicians that they are there. So Tamil channel with some music channel was entertaining enough. But we encouraged them for a little bit of singing and other things, but they're so tired. But there were other initiatives taken for yoga, meditation and other things. But I didn't find the younger population, greatly thrilled with yoga and meditation. They were more happy with just the phone in their hands. But definitely it's a stressful job. So they definitely need to be, diverted and from the stress.
Thank you, ma'am. Ma'am, one more question to Soumya. If a nurse become a COVID positive, after what is the period? After how long the nurse will be joining back to her duty, or in case she joins, which area she will be posted? She will be posted in the same COVID area, or any change of duty being given?
Okay. So what actually happened with us was that initially it was like I developed any symptoms. Initially we did not have any swab testing that was going on. For some reason, the government decided they're not going to do swab testing initially. At that time, if we had symptoms, we just had to quarantine ourselves for the entire household would quarantine ourselves for 7 days with symptoms, with 7 days. At the end of 7 days, you have to call back and again assess for symptoms through 111 our government site, where they assess you, and basically it's pretty basic, like 7 days of quarantine if you have symptoms. Suppose I am somebody in the house developed symptoms and I have no symptoms, I have to quarantine myself for 14 days. and wait for the symptoms. At the end of 14 days, even if you don't have symptoms, you can always join work. Now the policy has changed. If I have symptoms, I have a website where I can, my hospital website where I can log in, and I have to ask for a swab test to be done, which they will do it in the next 24 hours. They'll give me an appointment time. I have to go and get my swab, nasal swabs done. And once it's positive, then I still have to wait for my symptoms to go down. And before joining work, I always, even if I'm symptomless, I have to go and do a nasal swab again. That's the current guidelines. For somebody like me who has never been infected, I have to, since I work in a COVID now, since we don't have active COVID patients, we have COVID protected zones and COVID contained zones. COVID contained zones is an ICU where, in case there is a second wave or 1 or 2 surplus that's coming in from the other hospitals, we'll still take them. So those nurses, the entire system in which they're coming in is different. The pathway in which the physical pathway they come into the hospital and leave is completely contained from the rest of us who are working in the COVID protected zone. So for me, every 2 weeks, I have to, it's my responsibility to ensure that I go and do a nasal swab. They also do a COVID antibody testing for me. So I'm sure that the logic doesn't work out, that even if I do a nasal swab, I still could be infected, or I still, the point at which I did a nasal swab, I might be negative, but the next evening I might have got infected, but still, so you still wear the fluid resistant mask when all throughout the hospital. But when you join back after work, if you don't have any other comorbidities, like Selma ma'am said, the comorbidities that we were discussing were asthma. Basically, they would always be shielded, and they would be put in COVID protected zone or in a zones where they're very, very less risk, like a dawning zone, or assisting with documentation, assisting with staff, the logistics. They would be placed like this, but it would always be assessed back by the occupational health department and self-assessment as well. And if you feel good about it, you can go back to work, provided your nasal swabs are negative. That's what we're doing now. They're giving nasal swabs every 2 weeks. And I think the swabs are more painful than the actual COVID, because they really get inside and do that. Yeah.
Thank you, Soumya.
Yeah, I hope that answered the query.
Yeah, of course. One more.
One more thing I had to add on to.
One second.
Sure. Oh, me? Okay. So one more thing that my hospital did was give us unlimited data for 6 months. So our mobile phones have unlimited. We got free data for unlimited data for 6 months as a thank you from our hospital. So it was nice. It reduced our stress a lot. Sorry, continue, please.
Thanks, Soumya. But a little to add. From the onset, what we do here is, when a person is actually reporting symptoms, we keep them quarantined for 2 days, because sometimes it may just be a plain flu. It may be just a plain cough, because we cannot just tell everything as COVID. So we watch for 2 days, and after 2 days, there's of course under isolation, self-isolation. And after 2 days, they are actually called back to the staff clinic, and if the symptoms persist, a swab is taken. If they're positive, and the symptoms are mild, and if they have a facility for home quarantine, we can always suggest that. But most of our nurses, what they do is they don't have a facility for a separate home quarantine, so they get admitted in the ward, and once the symptoms subside, we discharge them. But
There is some connectivity issue. We couldn't connect with the ma'am. Salma ma'am. Participants, kindly bear. There is some connectivity issue. Ma'am will be joining us shortly.
Any questions further? Julian, can we have the vote of thanks? So in case she gets connected, we'll ask her to speak up.
Yes, ma'am. Good evening, all. Gratitude creates most wonderful feeling, strengthen the relationship, and it makes us better human beings. Before I propose vote of thanks, I would like to express my heartfelt thanks, appreciation, and prayers to all the frontline workers, especially all the nurses who stand like a warrior against the deadly virus and safeguard the society. Thank you so much for your untiring effort, dedication towards our profession. You have proved that nursing is not only the pills and charting, it's all about being being able to love people when they are at their weakness moment. I thank God Almighty who has had control on everything, shower His blessings to complete this webinar successfully. On behalf of Fundamentals of Nursing Department and MMM College of Nursing, I convey my deep sense of regards to Ms. Soumya Antony, who have shared her work experience extensively with human touch and professional touch. Thank you, Soumya. We are delighted to present e-certificate of appreciation to Mrs. Soumya Antony. Kindly accept. Thank you, Soumya. Next, my deep sense of gratitude to Mrs. Salma Thomas, Deputy Nursing Superintendent, who have accepted to use this platform to share her valuable knowledge and critical viewpoint on professionalism during this pandemic. Thank you very much, ma'am. It's our pleasure to present a certificate of appreciation to you, ma'am. Thank you very much.
Okay.
In her absence, we will send her through mail, ma'am. I express my heartfelt thanks to Dr. Rosalyn Rachel, Principal, MMM College of Nursing, for her selfless commitment in planning and creating the platform to disseminate professional values to all, with the aim to enhance image of nursing in the society. Thank you very much, ma'am. I wish to express thanks to our Vice Principal, Dr. Lata, who always smilingly supported and guided in all the endeavors of this webinar. Thank you very much, ma'am. And my special thanks to my first year team for their encouragement, positive energy, and team spirit to complete this webinar. My heartfelt thanks, dears. And special mentioning to all my seniors, colleagues, friends of inside and outside of MMM College of Nursing, and our non-teaching faculty member of MMM College of Nursing for your prayers and support. Thank you very much. Thank you for your patience listening. Thank you, ma'am.
Thank you so much. Thank you, Soumya, and all the participants for joining. Kindly, I hope you would have filled your feedback form, and you will be getting your e-certificates. In case you have any trouble, you have our numbers. Contact us. We'll help you. I hope you have filled your feedback form. Salma is coming on the line. 1 minute. Yes, Salma. Oh, no problem. Thank you. Thank you so much. I'll talk to you. Yeah. Her mobile got switched off. So anyway, thank you so much, all of you, for joining. God bless you all. Whoever is in the field, continue to do your services. Our prayers are there with you. Thank you. Thank you so much. God bless you all.